Before we get started in the session, we are going to have a quick education update. So I want to welcome Brittany to the stage just to keep everybody informed with what's been going on in regard to education.
Awesome. Thank you. This is the same presentation that I provided last year. So for those of you that were here, just a few updates. And then for those of you that are new, just a little bit more information on the committee. So we are a group of adult and pediatric specialists. It's multidisciplinary. So obviously I serve as the pharmacist member. It is a 3-year term with an application process. I'm on my final year of my term. So come next year, we would be filling the pharmacist position again. You do have to have experience with CF, and then there's preference for having experience with both creating and reviewing educational materials, as well as developing new CF education. So these applications will come out on the listserv, like I said, later when we're recruiting for the pharmacist position. This is our current member group, so I'm not going to read through everyone, but you can see the current members as well as the new members that will join our committee this session. So what we do, we ensure that the quality educational materials are available to both people with CF, their families, and then CF care centers. What we're actually doing is reviewing for accuracy, applicability across centers, as well as appropriate reading level. And then we're identifying areas of greatest need. So if anyone has logged on to the NACFC and looked at the documents that are available, you can see that several of them are outdated and certainly changing with the advent of modulators. So we're continually reviewing that as well. And then we review the educational abstracts for this conference. So these are the materials that were approved since we met last year. So a few additional CF RISE modules, the CF-related diabetes manual, as well as the introduction to CF to patients and their families, so that big book that's now on its 7th edition. So I sent this out on the listserv last week, but this is just another resource of CF education resources that are available from members of our community, both pharmacists and physicians. So that's not a complete listing of what's available on NACFC, but these are just other resources that are available if you're interested in reaching out. So how do you find it? As I keep saying, NACFC will get you there in the resource library, or you can always email the resources at cff.org to ask if they have something, order it, or if you would like to submit a new education material for review. So here's just a couple of quick screenshots to show how to order those hard copies if you wanted them. Certainly you can always print them as well. And then other things you can do, like I said, is submit things to our committee for review. So if you've developed a really cool patient information sheet, something that can help walk through new medications, please consider submitting that. Notify us if you find stuff that is out of date or not necessarily applicable anymore. Distribute this education to the CF community. We are all putting the time in to make these documents, review them. Certainly we want to see them used. And then submit new things.
Okay, so thank you guys for coming to PharmASSISTing, the multidisciplinary team, transition of care and care models. My name is Wendy Bullington, and I am the pharmacist at the Medical University of South Carolina Cystic Fibrosis Center for both adult and peds. You will meet my co-moderator in just a minute, Brittany, but we want to thank you for being here. Our objectives today are to discuss some important transitions of care that occur over the CF patient lifespan, to formulate strategies to improve communication and patient safety across patient care transitions, and to describe strategies to assist with the medication access concerns during transitions of care. I'm sure you all know, as we take care of our CF patients, transitions of care are very important. We watch them transition from peds to adults. We watch them have families. We watch them potentially transition to transplant or palliative care. And it's important that we as pharmacists are able to work with the other teams around us and our other pharmacists to really prevent medication errors and to make sure our communication is seamless. So hopefully today we will have some tips to help you through this process. Now I'm going to introduce Brittany.
All right, thank you guys for being here. We are going to go ahead and start with our first speaker, but before that, I just wanted to let you guys know that we're going to have a question and answer between each speaker. So if you can put your questions on the app, on the NACFC app, or you're welcome to come up to one of the mics, but just a reminder, please make sure that you do come up to the mic. Our session is recorded, so we want to make sure that we can hear your question whenever that's made available later. So our first speaker is going to be Dr. Sarah Kubiak. She's the clinical pharmacist at Boston Children's Hospital. She cares for both pediatric and adult patients living with CF. She will be discussing transitions of care throughout the CF patient lifespan. So please welcome Dr. Sarah Kubiak.
Good morning. It's good to see everyone here in Boston. Right. So no disclosures today from me. And today I'm going to be talking about how the CF pharmacy team can assist the multidisciplinary team in helping patients with CF through transitions. So we all know that transitions are unavoidable and a part of life. There can be fun and exciting transitions like going off to college. There can be not so fun transitions like hospital admissions or potentially insurance mandated pharmacy transfers. But either way, if we ensure our patients are prepared and supported, transitions can be smooth, allowing patients to enjoy life's adventures and at least successfully make it through the unavoidable ones. For people with CF, we know that unsupported transitions can result in lapses in care and can have negative impacts on health outcomes. So how can we, the CF pharmacy team, help prepare and support our patients for transitions? And what are some ways that communication can help ensure that the transitions are smooth and successful? So the transitions we'll be focusing on today are pediatric to adult care, inpatient to outpatient, insurance changes, transplant, and palliative care. So I wanted to take a moment to mention and appreciate some of the opportunities and resources that the Foundation has offered that have helped me to better assist our patients in all aspects of care, including transitions. And I'm sorry if everyone is familiar with all of these opportunities, but just in case there's the one person out there who isn't. Believe it or not, 2 years ago, I was the first pharmacist to step foot in the CF clinic at Boston Children's Hospital. And I wouldn't have been able to establish this role without the award for a pharmacist outpatient clinical pharmacy services. Again, I was the first CF clinic at my institution, so I had no one to train me on how to function in this role. And the CF pharmacist mentoring program connected me with an experienced pharmacist mentor who has supported me immensely throughout this transition. So a big thank you to Emily and the Dartmouth CF team for allowing me to visit and learn so much for you, and thank you to Laura and Dave for connecting us. All right, so the CF Pharmacist webinar series, if anyone has watched this, you know how helpful it is. It's been super helpful to me, especially with precepting. So these presentations are presented by our friend Jeff Zobel, and you're able to record the presentations. I've shared them multiple times with new team members, students, and residents. And of course, the listserv. This is where we all turn to each other for questions big and small. It's so important to have an experienced team to turn to and to share our knowledge and experiences. To have the support and camaraderie that this group offers has been so helpful to me. And to have direct access to the field's experts is pretty amazing. This past spring, our CF team had the opportunity to participate in the Partnership Enhancement Program training session. This training provides tools on how to better connect and communicate with patients and families, and also suggests ways to structure clinic visits to ensure that patient and family goals are being addressed, as well as the team goals. For me, I really learned great communication strategies that applied directly to medication counseling. In the last year, I've had the opportunity to participate in a couple CFLN projects with my teams. I've learned so much from these QI initiatives and have been able to apply what I've learned directly to practice. So a couple of resources that I'll go through today that apply specifically to transition our CF Rise and the Navigating CF series on cff.org. So CF Rise, of course, this is our go-to resource for all things related to CF transition. It's a transition tool set created by CF team members and families of people with CF. It provides patient knowledge assessments, responsibility checklists, and also care team resources. It focuses on different milestones for patients to reach so that caregivers can successfully pass along CF management. So the idea is that the patient slowly goes from depending on the caregiver for all aspects of care to engaging in care, to managing care, to leading, and then to owning all aspects of CF care with caregiver support throughout the way. So for us, as members of the CF care team, how can we help make sure our patients are prepared and reaching these milestones towards independently managing their CF therapies? At BCH, we've used CF Rise as the backbone to our transition educational framework, and we've assigned these milestones to fitting team members. Today, we're going to be reviewing the chart of milestones and identifying which milestones are fitting for the CF pharmacy team to take ownership of in terms of teaching and assessing for patients and families. Understanding the roles and responsibilities of CF care team members. I think this is important, of course, for all team members, but it's been particularly important for me as I'm a newer member to the care team. Patients and families aren't used to having a pharmacist in clinic, so whenever I meet a patient or family for the first time, I make sure I introduce myself and fully explain my role and how I'm there to help and how I can be a resource to them. Of course, a perfect milestone for the pharmacist to teach and assess is knowing the names of medications, understanding what they do, and learning about new treatments as they're introduced. For this milestone, it's important for us to involve the patient from a young age, using age-appropriate language to make sure patients understand their therapies. Understanding CF-related insurance, patient assistance, and financial management. I think this is perfect for either the team's pharmacy technician or the pharmacist to teach and assess. If you're lucky enough to have a pharmacy technician support like I do, thank you to Michelle. This is another great opportunity for the pharmacy technician to help with assessments. So managing all insurance and financial aspects of CF care, ordering new treatments, coordinating refills, and copays. This last category, taking CF treatments and therapies, in my opinion, is really entirely built for the pharmacy team to teach and assess progression towards medication independence. Keeping in mind that the goal is to teach and instill good medication practices with caregivers so that they can have the tools to pass on as their child grows and gains independence in their CF care. Again, including and encouraging patients from a young age to participate and be engaged in their care is super important. And these milestones really relate to the pharmacist's role in helping patients with sustaining daily CF care. Sustaining daily CF care is important through all transitions, and ensuring that patients and families have a good routine and good foundation will help ensure that they can continue this throughout times of transition. These are some of the questions that I ask patients and families during my annual pharmacist review to help assess and identify potential adherence barriers, and also some pharmacy interventions that can help patients overcome these barriers. So the first question that I ask is to assess the overall level of adherence. Do you feel like you can keep up with your medication doses? It's important to avoid words like adherence and compliance, and we have to remember to use our partnership skills by expressing empathy, acknowledging challenges, and praising efforts. I then follow that up with how many doses per week do you miss on average? And if the patient reports missing no doses, I ask what their secret is, so that I can perhaps give tips to patients that might be struggling. If patients do report missing doses, this is a great opportunity to review missed dose management. So if the patient is on a modulator, make sure they're prioritizing the combo tabs and ensuring there's at least 6 hours between doses. The next question I ask is meant to identify schedule or burden barriers. Do you typically miss doses because you forget or because it doesn't fit into your schedule? Some pharmacy team solutions to this barrier are to recommend reminder systems, help patients with a medication schedule that incorporates their daily activities, excuse me, and also to potentially streamline medication regimens. The next question I ask is meant to identify educational opportunities or identify potential mental health concerns. Do you ever skip doses because you feel like the medication doesn't help or there's no point? Some pharmacy team solutions are to assess the patient's understanding of medication efficacy and potentially provide education on the importance of preventative therapies. Some other pharmacy team solutions are to identify any potential mental health concerns, such as feelings of hopelessness. This should, of course, be raised to the appropriate CF care team members. The next question is meant to help identify access barriers. Have you had any difficulties obtaining refills due to insurance issues, high copays, or pharmacy stock issues? This is the opportunity for us to check in on PA statuses or any potential insurance preferred alternatives to ensure patients are enrolled in copay assistance or funding programs, and also to potentially optimize or consolidate pharmacies. In order to identify potential side effect barriers to adherence, it's important to perform side effect screenings or assessments. If side effects are identified, discuss mitigation strategies to try or potentially discuss dose adjustments with the patient and CF care team. So moving back to assessing transition readiness, a really great and efficient option for documentation of milestone progression is to embed age-specific assessment questions into the pharmacist note template. And Emily is going to be sharing some of the specifics of her practice with this. It's also important that the pharmacy team is involved in developing your center's educational framework for transition to make sure the team is aware of how pharmacy can be involved in medication-related assessments. In terms of communication, at BCH, we have quarterly transition meetings where all care team members from both PEDS and adult teams join, and the PEDS team presents the patients who are being considered for transition to the adult care team. This is a great mode of communication, and I love that all of our multidisciplinary team members join and participate. So a tool that you might be familiar with or might already be using at your center is the Daily Care Check-In. It's a validated tool by the Foundation's Success with Therapies Research Consortium that was developed to help identify common roadblocks that people with CF face with sustaining their daily care. It's an 18-question survey for patients to complete, and if roadblocks are identified, they provide a roadmap which offers various solutions and assigns the most fitting CF care team member to implement the solution. And not to spoil the surprise, but the pharmacist is named as the most fitting care team member to address many of these roadblocks. If you or your center has interest in utilizing this tool, email the Partners for Sustaining Daily Care at the email address below. So I'm still very much in the learning phase of insurance. I'm lucky enough to have been pretty sheltered from this in my inpatient days. But the Navigating CF series on cff.org is a great guide to insurance for patients and families, and has also been super helpful to me as an outpatient pharmacist newbie. When I joined the outpatient teams, I quickly realized how complicated prescription coverage can be and how important it is to have a strong team to support our patients in working through insurance challenges. We are dealing with extremely expensive medications, many with restricted access issues, and obtaining coverage often involves jumping through multiple hoops. The most important thing that I've learned about insurance transitions is that early awareness and planning for anticipated changes is key to avoid complications leading to delays in therapy. Our team's technician and I always encourage patients to communicate anticipated insurance changes with us and the social work team as soon as possible. This gives us the opportunity to review benefits and coverage together so that we can plan for any necessary therapeutic substitutions, submit new PAs, help them identify in-network pharmacies in case they need to transfer, and ensure they're enrolled in any eligible copay assistance or funding programs. I also think it's important for patients to maintain somewhat of a medication cushion. I don't endorse stockpiling of meds per se, but I do think that maintaining about a month's supply of medications can help prevent lapses in therapy for unanticipated insurance hiccups. In the instance of inpatient admissions and discharges, I think that helping with medication planning and communication are key opportunities for the pharmacy team to assist. In terms of patient communication, of course, we can complete admission and discharge med recs. We can do med teaching for new therapies, and we can help patients incorporate any new therapies into their existing med schedule. We can help patients be prepared by notifying them before admissions of any non-formulary medications that they're taking to make sure to bring them with them if they're being admitted. In terms of communication, we can work with the case management to make sure that any new medications that might need PAs or specialty pharmacies are identified and planned for to avoid any delays in therapy once the patient is discharged. At BCH, we have weekly multidisciplinary rounds, an hour for the peds team and an hour for the adult team, where we discuss patients that are currently admitted, patients that were recently discharged, and we also discuss upcoming clinic visits. This really helps with planning and also communicating plans amongst the inpatient and outpatient teams. Participating in these rounds has been helpful both to me and to the team and helping to assist with medication-related teaching and planning. A great mode of communication that Wendy and her CF team utilize at MUSC is pharmacist documentation of a discharge antibiotic note for patients discharging on home IVs to make sure that durations are clearly communicated, as well as the plan for lab monitoring. When patients are being discharged, communicating plans with the clinic pharmacist, as well as the outpatient pharmacist, can help ensure appropriate follow-up and prevent medication delays. In some cases, this pharmacist is the same person. So I guess the benefit of that is that no extra communication is necessary. So this leads us into establishing a pharmacy network. For patients that aren't able to utilize the pharmacy at BCH, I found it extremely helpful to establish key CF pharmacists and liaison contacts at the most frequently used outpatient pharmacies, especially the specialty pharmacies. Instead of waiting on hold forever and potentially being connected to the wrong people, I've established a direct contact that I can reach out to, and of course they can reach out to me for communication and clarifications in order to identify and resolve med issues more quickly so that we can prevent delays and improve patient care. Of course, the ideal scenario is that patients are able to utilize their own institution's pharmacy. In my own experience with our institution's specialty pharmacy, the integrated health system CF pharmacy team model allows us to provide a level of care to our patients that is truly unmatched. Communication, planning, and patient education is optimized, and our patients feel secure and supported, knowing that the CF pharmacy team that they know and trust from clinic is the same team that is providing their medications and ensuring that everything is safe, in line with their CF team's plan, and of course is billed properly. A truly life-changing transition that we are thankfully seeing less and less of these days is transplant. Thank goodness CMS requires a pharmacist on every transplant team, so my key piece of advice on ensuring a smooth and safe post-transplant plan for patients is establishing contact with the transplant pharmacist so that medication lists and changes can be shared, and so that you can co-establish a medication monitoring plan for the patient. Hopefully, end-of-life care will be something that we encounter once our patients have reached a ripe old age. I fortunately do not have experience with assisting the team with palliative or hospice care, but I came across a guideline from ASHP that provides a really great comprehensive description of the pharmacist's role in palliative and hospice care. The World Health Organization and U.S. Department of Health and Human Services stipulate that end-of-life care must take a patient and family-centered approach to maximize quality of life while minimizing suffering. In this guideline, I came across a few key roles for the pharmacist to assist with in helping the team support patients through end-of-life care. Pharmacists can review pharmacotherapy and facilitate discussions with patients, caregivers, and families to reset therapeutic goals. Pharmacists can review and provide recommendations on managing ineffective or non-essential medications. And pharmacists can also recommend alternative routes of administration when traditional routes are not feasible or impractical. This guideline recommends that a pharmacist should be a member of every PHC team. So hopefully, if this is a transition that our patients face, we will have a strong pharmacy team to help and support them. There are so many opportunities for the CF pharmacy team to assist the care team in helping patients prepare for transitions in order to avoid lapses in therapy and to support sustaining daily care. By optimizing communication and using our tools and resources, we can help our patients be prepared so that transitions can be navigated smoothly and our patients can focus on enjoying life's adventures.
Thank you so much for that great presentation. Thanks, everyone. If you have a question, please go ahead and submit it online or come up to the microphone. We already do have one question online for you. It says, "Thanks so much for great insights and appreciate the resources shared since I am new in this role. Do you have any tools or resources that you use when patients are getting off their parents' insurance plans and selecting their own?"
So as I mentioned, I'm still in the learning phase of insurance. I do work closely with our social work teams and my pharmacy technician, Michelle, who's here. And it's really, for me, I'm not aware of any specific tools for this, but I do know that early awareness, knowing that they're going to be switching plans soon is important, so that our social work team and our technician can work with them on choosing the right plan for their coverage.
So we do have another question. How do you manage between clinic needs and discharge med-recs? We see patients in clinic every day, so I've found it hard to be able to own the admission and discharge med-recs, but would love any tips for this. Who covers this when you are out of office?
That is a great question. And at Boston Children's, we actually do not have pharmacists providing discharge med-recs for most patients. Luckily for our CF patients specifically, we have very few admissions these days. And I don't necessarily get to do them with all patients because I'm also in clinic every day. But if we do communicate early with the inpatient team and they let me know when a patient's discharging, it's especially important for me to meet with them if they're starting a new medication. So I do try to prioritize the patients that are starting a new medication so that I can at least do teaching with them before they leave. And even if I'm not able to meet with the patient, I can still review their medications to ensure that they're in line with what the plan is.
So I have a question.
Yeah.
So I've been in adults for a long time. I've been in peds for only 2 to 3 years. How do you, or have you found any helpful tips when you're trying to do the med teaching during transition to older teenagers and the parents constantly want to take over and step in? And I feel like this is an area I really struggle with because I try to respect the parent, but I'm also like truly trying to get the teenager to answer my question.
Yeah, it's definitely something that I encounter as well. When I know that a teenage patient or a patient that has a little bit of an overbearing parent is coming in, I do try to plan and have my pharmacy resident with me so that when we both go into the room, I can have the pharmacy resident kind of chit chat with the parents while I am talking to the patient, and that is one thing that's really worked well for me.
Wonderful. Do you mind, do you have any tips when transitioning patients from peds to adult program when one program has a pharmacist and the other doesn't?
I do not have any tips for that. So I have somewhat struggled in covering both peds and adult. I would love to have an adult or peds pharmacist so that we could share the role. But also, I think it's important for pharmacists to be able to cross-cover each other for vacations and stuff like that. But I personally, when I started this role, I think I was encouraged to only cover one team, and I just did not feel comfortable not having coverage for the other. So I've chosen to kind of spread myself thinly and do the best that I can.
I understand. You mentioned a pharmacist note template. Is this an online tool or something you would be willing to share?
So this is not an online tool, but it is something that my pharmacist mentor has made. So this past summer, our institution transitioned from Cerner to Epic, and I, of course, had just completed making my template note for Cerner when this happened. And dot phrases and smart phrases I was not familiar with, and instead of reinventing the wheel, I reached out to Emily to see if she had any templates that I could borrow and adapt, and so that's what I did. But I think we do have a lot of pharmacists out there who have great templates, so I think reaching out to the listserv to see if anyone is willing to share is a great idea.
How do you track patients who are in the varying phases of the transition process to be prepared to discuss it at quarterly meetings?
So we do have, as part of our educational framework, we have kind of a patient checklist that we've adapted from CF Rise. And as we, the different team members are assessing these different milestones, we kind of check them off. And it's kind of an ongoing conversation, especially as patients reach college age. As we're assessing, the provider is discussing with the patient what their feelings are on transitioning to adult care. And we kind of use those both together to assess if the patient is ready.
Wonderful. And the last question we have is, what is the email to request the daily care check-in list?
Ooh.
Or Could you maybe share it via the listserv later?
Yes, of course. It was
Yes.
on one of my slides.
We will share it with the listserv. And if whoever asked that question isn't on the listserv, please find one of us or Dave Young, and we'll get you added to the listserv. Thank you very much.
Thank you.
Thanks so much, Sarah. So next we're going to have Kelly Leal. She's an advanced certified pharmacy technician at the University of Louisville, Adult Cystic Fibrosis Care Center, and specialty pharmacy located in Louisville, Kentucky. Kelly has been working in CF Care since 2023, but started her pharmacy career in 2014 at Walgreens. She then moved to the Walgreens Specialty Pharmacy, working her way to becoming the specialty pharmacy's operation manager before moving to U of L Health. She brings a wealth of expertise and dedication to her role, focusing on enhancing patient care and improving medication access for those living with cystic fibrosis. She lives in Louisville, Kentucky with her husband and their daughter, and in her free time, she enjoys spending time with her family and being outdoors. Please welcome Kelly Leal.
My name is Kelly Leal. I'm an advanced specialty pharmacy technician with the University of Louisville Adult Cystic Fibrosis Care Center in Louisville, Kentucky. Today I'll be discussing a topic that's important not just to patients, but the entire healthcare system: medication access issues and how to overcome them. I have no disclosures. Access to medication is an essential part of effective healthcare. Yet for many patients, particularly those with chronic conditions like cystic fibrosis, barriers such as high cost and insurance limitations can prevent them from receiving the life-altering treatments they need. In this presentation, I will discuss medication access barriers related to cost of care, identify strategies to overcome these challenges, and evaluate how we can help educate our patients so that they are able to navigate these obstacles. A study published in 2023 looking at the cost burden for people with cystic fibrosis found that 1 in 4 people with cystic fibrosis faced unmet prescription needs. I want to take the time to talk about a few of the medication access barriers I have encountered and what we can do from a pharmacy standpoint to help overcome them. I have broken down the different access barriers into the 3 most common categories that I have encountered while helping our patients: provider availability, cost of medication, and lack of resources. I will discuss each of these categories in more details in the following slides. The availability of care teams to answer clinical questions about medication, help patients navigate the healthcare system, and address medication access issues, and handle pharmacy-related administrative tasks are a key aspect of ensuring that patients receive the right care at the right time. This availability directly impacts patient safety and effectiveness of treatment and the overall patient satisfaction. By being present and accessible, care teams help ensure that patients receive the care they need to thrive. Medications are an essential part of treating many health conditions, and many people living with cystic fibrosis may be on multiple medications to treat their conditions, and managing them can be complex. Patients often have questions about how their medications work, potential side effects, or how different drugs might interact. Pharmacies may also have questions or need clarification before they are able to fill a patient's medication. When we are readily available to answer these questions, it helps ensure patients take their medication correctly and safely. This can prevent complications, reduce risk of adverse effects, and improve overall health outcomes. Next, I want to talk about patients navigating the healthcare system to obtain their medications. So what does this look like? Some examples are knowing who to reach out to if there is a problem getting their prescription or if they cannot afford their medications. Do they know what to do if their insurance changes or if they lose or damage a prescription? It is important that we make it as easy as possible for patients to know what to do if an issue comes up to avoid gaps in therapy or unnecessary cost. So, how can we help our patients? Conducting medication review during clinic appointments and providing patients with the list of their active medications is a great starting point. It is important to let patients explain what medications they are currently taking and how they take them. This approach gives us a clearer picture of their actual medication regimen and helps confirm that they understand how and when to take their medication. Our goal is to ensure that patients feel safe and comfortable sharing their actual medication practices with us, rather than simply telling us what they think we want to hear. If a patient mentions they aren't taking a medication, this opens up the chance to find out why. Is it due to cost, time constraints, side effects, or other issues we can help address? Ultimately, we need to meet patients where they are in terms of their ability and willingness to follow their treatment plans. The best thing we can do is to make ourselves known to our patients. When you meet with your patients in clinic, tell them if they have any issues related to filling or paying for their medications to reach out to you. At our clinic, we have a printout that we give each patient at every appointment that has the care team member, their role and best contact number so that they know who to reach out to. Another resource that is good to give patients is a list of their filling pharmacies. I have had patients tell me they've stopped getting their medications refilled simply because they did not know where to call. A good rule is to never assume a patient will reach out to you with a problem. Even if a medication is prescribed and a patient is willing to take it, it won't benefit the patient if they cannot obtain it. There are many reasons why a patient may have trouble getting their medicine. If they're out of refills, lost medication, pharmacy shortages, high costs, just to name a few. When we are available to assist with these issues, we can help patients navigate the healthcare system, find alternatives if necessary, and ensure there are no barriers between the patient and their treatment. This accessibility can make a huge difference in the patient's ability to manage their health effectively. There are pharmacy-related administrative tasks, which while might not seem as critical as direct patient care, is a significant role in patient care and medication access. Tasks such as completing prior authorizations and appeals, which I'll discuss in depth in the next slides, processing insurance claims for patients filling at health system pharmacies, calling pharmacies to help with billing and provide processing information for the patients that fill at offsite pharmacies, and maintaining accurate patient records are all essential to the smooth operation of the healthcare system. When we are available to handle these tasks efficiently, it prevents delays, reduces errors, and ensures that patients get the care they need without unnecessary obstacles or costs. For many of our patients, the high price of prescriptions can be overwhelming and sometimes impossible to afford. As a pharmacy technician, I have seen these struggles firsthand. Prior authorizations, high copays, and lack of insurance are a few of the most common obstacles that we have to help patients overcome when it comes to the cost of their medicines. Patients with cystic fibrosis often require specialty medications that are a vital part of managing their complex condition. These medications are often expensive and require prior authorizations before their insurance will provide coverage. To complete a PA, you will need detailed information to submit to the insurance plan. While every plan is a little bit different, most plans will require chart notes from the most recent clinic visit, most recent PFTs, labs, genetics, current height and weight, medication history, and previously tried therapies. Unfortunately, this is not always enough to get coverage. Sometimes even after going through the prior authorization process, the insurance company will deny coverage. If this happens, a request to appeal the decision can be submitted. You will need the PA denial letter, all documents from the original PA submission, letter of medical necessity, and some plans may require 1 to 2 peer-reviewed articles showing medical necessity. This process can be long and stressful, especially for patients who need their medications right away. In some cases, if the decision is not overturned, a peer-to-peer review might be necessary. This process looks different for each plan, so it will be necessary to reach out to the plan directly to move forward. Even when medications are approved, patients can still have copays depending on their plan, and for some, these copays can be very high, making it difficult to afford their medication. Specialty medication required for the treatment for cystic fibrosis can cause financial burden for patients, even with patients who have insurance. And for those without insurance, the cost can be even higher. An article published in 2023 showed that an increase of $100 was associated with an abandonment rate of up to 75% for certain specialty medications. It is not uncommon for people to skip doses or stop taking their medication altogether because they simply can't afford them. The good news is there are several things we can do to assist patients in managing the cost of their medications. Manufacturer copay cards are designed to help reduce the out-of-pocket cost of medication, making them more affordable, particularly for brand-name drugs. Copay cards typically cover a portion of the copay required by insurance, easing the financial burden on patients. However, most copay cards have a yearly maximum amount they will cover and a maximum amount they will pay per prescription. This is why some cards advertise that patients can pay as little as $5, but the actual cost may be higher depending on these limits. To enroll, patients usually need to meet specific criteria set by the manufacturer, such as having commercial insurance and using the medication for an approved indication. Enrollment often involves providing consent for enrollment, basic information about their insurance and prescriptions, and in some cases, the patient must enroll themselves in the program. The pharmacy is not able to. Understanding the terms and ensuring eligibility is crucial for patients to maximize their benefits. This information is listed on the manufacturer's website. Many organizations offer financial assistance to people who are struggling to afford their medications. These programs can cover all or part of the cost of their medications, making them affordable or even free. A few foundations that are available for patients with cystic fibrosis are the Healthwell Foundation, the Patients Advocate Foundation, and the Assistance Fund. The foundations typically have diagnosis and income requirements and vary depending on the plan, which are listed on their website. NeedyMed is also a good resource to find financial assistance for patients who have coexisting conditions. It is important to understand why some people lose their insurance in the first place. There are many reasons this can happen. Some people may lose their job and with it their employer-sponsored health insurance. Others may age out of their parents' insurance plan, or they may just not be able to afford their premiums. Whatever the reason, losing insurance can be devastating, especially for those who rely on medications to manage their health conditions. In these cases, we can guide our patients to resources that may help them get their medications at a lower cost or even for free. Patient assistance programs, or PAP, are designed to help patients with limited financial resources or high medication costs gain access to medications that they need at little to no cost. PAP often covers a range of medications essential for managing cystic fibrosis, such as CFTR modulators, pancreatic enzymes, and inhaled antibiotics. To qualify for PAP, patients typically need to demonstrate financial need, often through income verification, and may also need to provide proof of insurance status. If they are underinsured, meaning they have active coverage but still have a high copay for their medication, they will need to provide proof. Each program may have different eligibility criteria, and the application process often requires coordination between the patient care team and pharmaceutical companies. These programs play a crucial role in ensuring that patients with CF can manage their treatment regimens, improving their quality of life and their health outcomes. Even with all the options for assistance, we still run into obstacles that can be nearly impossible to overcome. I want to take a moment to talk about something that we in the pharmacy community have been encountering more and more frequently: alternate funding programs. AFPs are designed to assist patients who cannot afford their medications. Often they are promoted as a way to get coverage by securing payment through grants or PAP, saving patients and employers thousands. While these programs sound like a dream come true, the reality is often far from it. These programs will exclude specialty medications from their formulary to make it seem as if the patient is underinsured in an attempt to gain coverage through PAP. If that is unsuccessful, they may require patients to fill their medications at pharmacies located outside of the country, exposing our patients to medications that are not regulated by the FDA. AFPs are usually managed by third-party companies that require extensive paperwork, multiple approvals, and endless back-and-forth communication. The process can be so convoluted and slow that patients are left waiting for months without the medication they need. I personally have encountered an issue caused by an AFP, which caused one of my patients to be stuck in a fight with the AFP, insurance company, and manufacturer for 5 months before their medication was approved, all because of the inefficiency and lack of transparencies that these programs exhibit. It's frustrating to see how these programs, which are supposed to help, can end up creating more barriers and dangerous situations for our patients. It is so very important that patients are aware of these plans when they are choosing their insurance. While we cannot tell patients which plans to choose, the CF Foundation has great resources available. Lack of resources such as income, access to reliable phone, internet, and transportation can significantly impact a person's ability to access medication. Patients with limited income might struggle to afford their medications, leading to missed doses or even complete discontinuation of their treatment. Without reliable transportation, getting to the pharmacy or clinic appointments can be difficult, resulting in delays in starting or refilling prescriptions. Without phone or internet access, patients may find it challenging to communicate with their care team, receive reminders about their medication, or access telehealth services, further complicating their ability to manage their health. Time is something I think we often do not think about as being a resource, but I would consider one. As our patients become older and able to work, starting families and living ordinary lives, they may feel the time burden required to manage their condition. Between work, clinic appointments, daily treatments, medication pickups, just to name a few, these tasks can quickly stack up in an already busy life and be difficult to manage. So how can we help? By offering services such as medication delivery or even bringing medications to patients' clinic appointments, pharmacies can help patients receive their medication even if they cannot travel to the pharmacy and save them time. As previously discussed, pharmacies can assist patients by providing information on financial assistance programs or by working directly with the insurance companies to lower the cost of medications. Collaborating with your clinic social worker can be highly beneficial. Social workers are skilled in connecting patients with community resources such as transportation services or programs that provide free or low-cost phone and internet service, which can help patients overcome these obstacles. It is important to ask patients what is their preferred method of communication. I have found that some patients who do not have access to phone but will respond by email. By working together, care teams can create a more supportive environment that promote better medication adherence and access, ultimately improving patient outcome. As I conclude, I would like you to remember one word: ask. I want to emphasize the importance of actively engaging with our patients about their access to medication. Not every patient will openly share their struggles or come to us with questions, which is why it is important that we take the initiative to ask. Many face significant barriers, whether due to financial constraints, insurance challenges, or simply navigating the complexity of their condition. It is our responsibility to advocate for our patients and be the bridge to help them overcome these hurdles. We are a vital resource here to support and guide our patients in accessing the care they need. Let's continue to be the advocates they deserve, ensuring that no one falls through the cracks on their journey to a better health.
Thank you so much.
Thank you.
Thank you so much, Kelly. Next, we have Emily Siemens. She is a center coordinator and a certified specialty pharmacist at Dartmouth-Hitchcock Medical Center. Emily was born and raised in New Hampshire, graduated from the University of Connecticut in 2018, and shortly thereafter returned home to begin her career as a pharmacist with a DH Specialty Pharmacy. She quickly developed a passion for the collaborative team approach of the Dartmouth-Hitchcock Cystic Fibrosis team and has a particular interest in developing the role of a pharmacist on the multidisciplinary care team. Outside of work, she enjoys exploring the U.S. national parks, walking on the beach, and traveling with her family. Please welcome Dr. Emily Siemens.
Hi, everyone, and thanks, Wendy and Brittany, for having me. As she said, I'm from New Hampshire, just a couple hours north of here, so welcome to our neck of the woods. Today, I'm going to talk about the pharmacist's role on the care team and the many hats that we wear. I have no relevant relationships to disclose related to this presentation. In addition to these session objectives, my few objectives are going to touch on telehealth in pharmacy services, the pharmacist's role in patient mental health, and summarizing pharmacy documentation best practices, as that's clearly been a hot topic today. You probably recognize this diagram as what we've known for a number of years, where pharmacists are in that second ring of recommended care team members. I think all of us in this room are eventually hoping to work our way into that middle section of required care team members, and there's some exciting updates, which I think we're getting closer. But this has been the common diagram for a number of years now, where pharmacists are in that recommended area, and therefore we have no standardized documentation or requirements as the CF Foundation has for all of these other disciplines that are included in that required team members. In 2020, my colleague Brian and I determined that we needed to standardize our approach, not only because we're at two different locations. I was at the Academic Medical Center in Lebanon in central New Hampshire, and he was in our satellite clinic in the southern part of the state. So we were, of course, seeing overlapping patients, but knew we needed to standardize our approach within our institution. We obviously had the foresight that hopefully we were going to work our way into that middle ring and eventually be required care team members, so we tried to get a head start on standardizing this. We created this study where we had patients complete a baseline satisfaction survey that you can see there on the right-hand side, and they would determine how they felt they each answered each of those questions with just the care team. So the downfall was that we had already been in clinic for a little bit of time and, of course, met patients and made interventions, but we were asking them to complete this survey with just the care team background, so assuming that we hadn't been there, and how they felt comfortable with their medications, how they knew their medications were working, possible side effects, drug interactions, just based on their interactions with the rest of the care team. We then completed this standardized pharmacist annual review that we had created, and then it had the patients complete the satisfaction survey again, and we measured the change in their survey responses. We knew that this was important because for the foundation, for patients, it's most important to know how patients are satisfied with their care. And then we also knew that the institution could look for a number of interventions and what type of interventions we were making. So we wanted to make sure that we had both of those tools justified. We documented our results in the medical record and categorized our interventions into those 4 categories and kind of tracked them separately. In conclusion, we found that a pharmacist annual exam improved patient satisfaction, and that patients found it beneficial to have a pharmacist in clinic as a member of the care team. The quantity of our interventions, despite only having 29 patients, because this was in 2020, so we only had a few months of data, we still found that the quantity of our interventions suggested that we should complete this annual review each year. Our limitations were, of course, related to the pharmacist in the exam room. We were the ones administering the survey, so there may be some bias from us sitting there with them. And, of course, the pandemic kind of halted our data collection pretty quickly. At that time, I also identified that I needed a way to better organize myself. So I created this outline where I, in an ideal world, will spend some time before clinic and gather patient data on this paper so I can be prepared going into team meeting. This gives me an opportunity to review the chart ahead of time, again, on a good day, and be able to go to team meeting and have valuable interventions to be able to discuss pre-clinic. This has also been extremely helpful for having learners. So with residents or pharmacy students that might come on rotation with me, it gives them a standardized approach for them to practice their visit as well. And of course, a methodic chart review that they can realize what we should be looking for as pharmacists. Again, this has evolved over the last 4 years, and I've really kind of added and removed stuff as time goes on to determine what the care team thinks is most important and what I'm finding my most valuable interventions are. There's also a benefit to bringing a paper into the visit. In an ideal world, I would like to never have to have my computer for infection control and to engage patients. We know that patients don't love when you're sitting there staring at a computer and not talking to them as a person, right? So having this paper is really helpful. And if I can print medication lists, that's great. It's just a little less dynamic, I found, that if others are making changes to the med list during the visit and I have it pre-printed, that there's kind of a barrier there. But I ultimately hope that I could make this more streamlined as time goes on and really decrease the use of the computer in the clinic room. In 2021, we did a similar survey with more patients this time. We were able to get 56. We had the same categories. There are two predominating interventions, the medication access and med rec. I'm sure you all realize that the med list can be a disaster, and so anything we're able to remove and streamline is extremely helpful. We had a lot of patient education and drug therapy optimization as well. We categorized our survey data a little bit differently the second time around and determined that it was most impactful to look at the strongly agree survey responses. So we wanted to know where we made the greatest difference and where patients didn't necessarily strongly agree at baseline, but then did after the visit with the pharmacist. So our four top categories were that we helped patients understand why they're taking each of their medicines, knowing that they're safe and effective by understanding possible side effects and avoiding drug interactions, that we helped them find easier ways to take their medicines, and we listened to concerns. We had the same conclusions as the previous study, just categorized our data a little differently. In 2023, Jeff and I decided we needed to translate this across 2 centers and really integrate in telehealth. COVID taught us we need to be able to incorporate telehealth into our practices, so that's what we tried to do here. We did have a number of logistical and staffing barriers in the way, so our N was pretty small for this data collection, but we were able to successfully do asynchronous telehealth visits where we saw the patient outside of the regularly scheduled clinic visit, which is often helpful, as you may have experienced, that patients are already in the visit for 2-3 hours, and the last thing they want to do is spend 45 minutes going through a med list with you and talking to you about all their medication access barriers. This had a fair amount of pros and cons, but I think we found that it just told us that we can incorporate telehealth effectively. In 2023, a group of us sent out a survey on the listserv. You may have participated in it, so thank you if you did, and you were one of these 60 responses. We kind of had the same idea moving forward, right? That we all knew that we had similar overlapping pieces to our documentation, but we also understood that it was very non-standardized. So in the listserv survey, we pulled out all of these documentation components to determine which pieces each pharmacist was asking. As you can see at the top, there were 4 of the most common ones were lab tests, reviewing meds and allergies, and patient adherence and CFTR modulator eligibility. Those are pretty common that a lot of us are asking. Much less common at the bottom, and maybe food for thought if you want to include them in your annual. This just further told us that our documentation practices vary widely, and if we eventually become required care team members, and there's a potential for us to need to develop our own standardized approach as a pharmacist, for the foundation to have us checking the boxes that other disciplines have to for registry purposes, that we really need to work on standardizing this. As of yesterday, this said draft manuscript, but now I am excited to share that based on the email we got yesterday, it seems we're inching a little bit closer to that center ring in the diagram. And in the most recent position papers, the committee acknowledged that the pharmacists being added to the core team improved outcomes for patients with CF, and noted that this incorporation into the care team may vary by institution because we have to take into consideration the resources available to ensure frequency and quality of services match the needs of people with CF within each care center. So I would definitely encourage you to read this if you haven't already, but it seems like we're getting a little bit closer, and further the need to standardize our approach to documentation is getting there. This is the diagram included in the position paper. You can see we've kind of made it into the center ring. It's not necessarily saying that we're required, but we are acknowledged as being part of that core team. We're in that same list with the respiratory therapist, social worker, mental health coordinator. And I like the dynamic of this diagram showing that we partner with essential consultants like outside primary care providers and refer to trained and trusted specialists while being supported by programmatic components like the registry coordinator and research coordinator. I highly encourage you to take a look at this if you haven't already. I wanted to go through my template now, kind of line by line, to share what I've streamlined over the last 5 years. I think this might have been what Sarah was alluding to that many of you are interested in, so I'm happy to share any information if helpful. But again, I am one of many, and this is just what I found has worked well for me. As you all probably agree, nobody reads beyond the first line of your notes, so I always have summary and recommendations, especially if it's anything relevant that I want the physicians to know. And then I continue to track my interventions. I don't do that as formally anymore, but I know that if I ever do need to go back and collect data, likely for the institution, that I would want to be able to pull those interventions out and track and categorize them. I then have the medication list, and I know we all have very different softwares and each institution's different, even if you have Epic like I do. But I find it helpful to have the medication note, the little green highlight there. You can make a note next to the medication that will then stay there until someone deletes it. So that's kind of where I keep track, like, oh, this patient switched their morning and evening doses due to daytime headaches. And then you can click through taking, not taking, and then that pulls into the medication list. So having a standardized template that pulls into my note has been really helpful and allowed our providers to have an updated med list. Bless you. I then have drug interactions, again, ideally pulled out before the visit, but often afterwards I have to review anyways. Pulling in the allergy list. And then I have a smart form that our team had built for adherence. Might be a little hard to read there. But it's some of the more common adherence questions, and that's largely based on our specialty pharmacy accreditation requirements. So that allows me to pull that into my list, but it's also very relevant for anyone to check. The responses at the top of that next page are what pull in from the smart form. And then I have a section that I find is the most relevant adherence-related questions that I like to be able to track over time. So specifically related to access and availability, and then how the patient remembers to take their medications. I like this as a free text section so I can remind myself next time that they have their Trikafta by their bed, but they also have their Pediasure ready to go, and that's kind of their routine for adherence. So that reminds me to check in with them next time to see if that's still what they're doing. I then have scheduled and non-scheduled medications separated out. Estimating missed doses tends to be something that patients are able to track, and I find that that's been effective for me to follow over time. And then we do have some pill boxes that we're able to provide to patients. I have both travel pill boxes so they can take their enzymes like in a backpack or purse. And then I have weekly pill boxes. So I kind of talk to the patient about their routine and determine if a pill box would be helpful for them to improve their ability to sustain daily care. And then I'm able to provide them that and follow up with them at their next visit. Again, I had an idea for QI at one point to be able to track if pill boxes improved adherence, but there's a lot of barriers, including time, in the way of doing all the fun projects that I want to do. I then have a section for side effects, make sure I review the order of inhaled medications, streamlining the number of pharmacies on their list. So kind of like we have extra medications on the list, I found that patients end up pharmacy hopping, but the pharmacies don't ever make it off of their list. So especially when acute meds are needed to be ordered locally, there are multiple pharmacies on the list and the provider has no idea where to send it. So that's actually something that I developed based on feedback from a care team member that asked if that could be part of my review process in cutting down and kind of clarifying what pharmacies the patients use. I then have a section for copay assistance, where I kind of review eligibility at the time. Ideally, we'll use that as a point of education for patients to remind them what they're enrolled in. As you've probably experienced, a lot of times patients don't even know what you do behind the scenes, especially if you have a really effective specialty pharmacy team that just overcomes the barriers for them. My modulator section is probably very similar to what many of you might do, tracking the start date, LFT monitoring, eye exam monitoring, making a note for when they're due for their next one. And then finally, I have a transition smart list. So I have specific transition questions based on age to determine a patient's readiness to transition kind of to those next milestones. So that smart list allows me to choose the age range, and then it pulls in this set of questions, again, making the medical record work for me and not have to do so much clicking, but have really a standardized approach to it. This is the example on the right there of the questions that I have for 18 and older, probably similar to what many of you might have pulled from CF Rise and experience with transition and you're on your own. I then have a free text at the bottom, transition readiness assessment, to kind of make notes like patient heading off to college next year but has no idea where his meds come from. We're going to work on that at the next few visits. And that's, again, something that I can reference easily before the next visit. Speaking of transition, we identified as a care team based on an XOC response that patients were often responding that they were asked the same questions over and over. And we really didn't realize that all of our annual reviews were overlapping with questions. For example, the respiratory therapist and I reviewed order of inhaled medications. So if we were doing an annual on the same day, the patient's like, I already answered this question. And of course, they're in there for too long as it is. And so of course that can get frustrating. I think the most interesting part is that we sometimes would get different answers. So that was like, what is the real answer here? But ultimately we just determined that we needed to streamline our medications. And even if we both needed it or wanted it in our annual documentation, we needed to communicate with each other and have only one of us ask the question, but then both be able to document it. So as a team, the coordinators reviewed all of our note templates of all the specific disciplines and then had a meeting to discuss who will address each of the common topics. So we chose the overlapping questions like that example and determined that I would review it during my annual and the respiratory therapist could include it. This, of course, emphasizes the importance of communication during clinic and sharing patient and caregiver responses, making sure that nobody's missing that, but also in between patients being able to chat with each other and kind of update, and therefore decrease the overlap in what we're talking about with patients. And that is all I have.
Thank you so much, Emily.
Thank you, Emily. So our final speaker is going to be Dr. Brittany Wright. We're going to introduce her back to the stage. Brittany is a clinical pharmacy specialist within the pediatric and adult pulmonary clinics at Iowa Healthcare. She also maintains an adjunct associate professor appointment at the University of Iowa College of Pharmacy. After obtaining her Doctor of Pharmacy degree, Brittany completed both PGY1 and PGY2 ambulatory care residency training programs. She holds board certification in ambulatory care and is involved in both didactic and experiential teaching, as well as several committees within her institution and the Cystic Fibrosis Foundation. Brittany's research interests include cystic fibrosis, medication adherence and access trends, implementation of pharmacy services, interprofessional collaboration, and quality improvement. So please welcome Dr. Brittany Wright as she covers a case study.
Thanks, Brittany. All right, I have no disclosures. And today I am excited to present a project that we completed at our CF Center. And so today I'll be talking about a new vision, the integration of ophthalmology services to a cystic fibrosis care team. I have one objective, and that is just to present this example of innovation in patient transitions of care. So coming right behind Emily here with the same diagram. Earlier this summer, we first saw this diagram as a draft paper, a position paper from the CF Foundation, re-envisioning the CF care team. And so I think everyone in this room is really excited for the highlighted part, including a pharmacist. But today I'm going to be talking more about ophthalmologists, which is now on this trained and trusted tier. So as we know, CFTR modulators have known or potential known ocular toxicity. Juvenile toxicology studies in rats demonstrated cataract development postnatally in days 7 to 35, and additional case reports were reported in ivacaftor-containing compounds, although other risk factors were present. But because we weren't able to determine exact cause, the monitoring still exists for cataract screening. However, since the approval of these medications, we have received more case reports in studies suggesting potential ocular toxicity, including the 4 that I'm going to highlight here. So Dr. Taylor Kauser presented 47 pregnancies and 26 infants exposed to ETI in utero or via breast milk, and no cataracts were reported, but as you'll see, only 2 infants were actually assessed. Dr. Jane then reported on 3 infants that were also exposed to modulators in utero or via breast milk and found to have cataracts within 6 months of birth. And then the last 2 case studies that I have are on children that initiated ETI and later developed papilledema or hypervitaminosis A. And so because of this potential for ocular toxicity, our team has decided to look further into this and see what we can do to potentially identify these patients. So a quick review on the 2 eye pathologies that I'm going to talk about today. I think most of us are familiar with cataracts, and so this is a cloudy, or essentially a cloudy changes to the lens, and currently the only treatment is surgery to remove that cloudy lens and replace it with a synthetic version. I think historically at our center, as well as many of yours, when we're evaluating the risk-benefit of modulators, the benefit is always greater than the risk of cataracts because we know there is an intervention available. I will say when these reports came out about papilledema, that shifted the thought a little bit because the diagnostic criteria is a lumbar puncture. Treatment includes removing the offending agent, which could be harmful to someone's CF, and then potentially adding on another medication. And so that did sway our always risk-benefit, favoring modulators. So providing a comprehensive eye exam requires thorough and attentive providers that are knowledgeable about these risks. This was a huge learning curve for my CF team. As you can read through this list, I wasn't actually familiar with any of them and what to advise our patients to talk to their eye care team about. And so without the education from our ophthalmologists, I wouldn't have had this much appreciation and, once again, knowledge to share with our patients. So identifying the need. As the age for CFTR modulators continues to decrease, we continue to hear common trends from our families, and we've used this information to identify the need. So some of these complaints or questions are, my local eye doctor doesn't see kids this young. How do I know that they're looking for the right thing? And lastly, what if they do find something abnormal? So that's from the patients and family side. I would also like to address some of our concerns and why we identified this need. So we have had trouble receiving adequate documentation when patients are getting their eye exams externally. So some examples here are difficult to read faxes, an eye exam that was probably incomplete. You'll notice it says not dilated. This medication list doesn't even have a modulator on it. So bringing up the question whether they were evaluating the correct things. And then my favorite, I don't even know what this says. So switching gears a little bit, and once again, this setup is going to be very similar for everyone in the room, but our pediatric specialty clinic had nearly 75,000 visits last fiscal year over 20 specialties. So we really view this as a one-stop shop. And I know Emily mentioned this in her presentation as well. A lot of times patients get tired at our CF visits because they're so long. And so this is a downfall, but also considering how difficult it is to have access, especially in some rural communities, we have found this still to be beneficial. So what was this process of integration that we used? So first we met with those providers and discussed this opportunity and need for collaboration. Once again, that was easier walking down the hallway in our pediatric specialty clinic with providers we already knew versus trying to reach out to every single eye care center in the state, many of which are also just optometrists and so potentially don't have the equipment to look for what we needed them to look for. Next, we discussed the benefits and service with patients and families. So upfront, we acknowledge that this would likely extend their clinic visit time, but bookended it with, we see the value in this because we think you will get more complete care. And then lastly, incorporating it into the CF clinic was possible because they had flexibility. And so because our clinic visits are so long and we're all in the same location, we could be flexible with timing for appointments based on the days of our CF clinic that were already established. So after we implemented this, we decided to look back at a chart review. So out of the pediatric patients seen in our clinic from August 1st of 22 for the upcoming year, and those that were receiving CFTR modulator therapy, we identified 3 main outcomes. So first we looked at the dilated eye exam. So once again, knowing when we think back to that slide I had that had all of those different testing techniques, knowing that the dilated exam is going to be the best to identify those potential ocular toxicities. Whether or not they were overdue for exam on an annual basis, and then abnormal findings. We reviewed 88 patients that were less than 17 years of age. And out of those patients, 91.3% had a dilated exam when it was completed at our institution, compared to only 31% outside of the university. You'll also notice a huge difference in those that were eligible or overdue for that eye exam. So we attribute a lot of this to scheduling on site and not kind of falling off of our radar. And then while this wasn't statistically significant, there were 5 patients who had identified abnormalities on their eye exam, all of which occurred at our institution. But I would attribute this to just a more thorough exam. So in our experience, lack of standardized documentation, inconsistent testing techniques, and reduced communication with outside providers has been puzzling. We don't know where to go. It adds to the list of things we're already trying to complete. However, ease of scheduling within a common location, shared electronic medical record, and then assurance that we're actually getting a complete eye exam has really led to success. Lastly, we know that our ophthalmology exams are being completed by pediatric trained specialists, which we can't always guarantee when it's being seen at a different institution or center. So in terms of next steps, I would say that our first 3 steps have led us to be quite successful. However, we still have next steps to complete. So that is to seamlessly schedule and maintain ongoing monitoring. So we're working with our core schedulers now to make sure those patients actually do get seen for follow-up routinely, whether that's annually or more frequently if they do have abnormalities noted. And then we're also working with our IT team. We have Epic, and we're hoping to utilize the health maintenance tab to start keeping track of those annual eye exams, because I think a lot of us in the room are like, oh, we'll just add it to our ongoing Excel spreadsheets and try to filter it by days, and then that just doesn't become realistic. So trying to find a way that's automated and also easily shareable with other team members. So certainly limitations. We know that this was a retrospective chart review design, which always can have impacts when you're reviewing data for data collection and interpretation. It's a small sample size. Even though it was almost our entire center, it still is one center. And then we lacked the randomization and self-selection of the desired location. And so intrinsically, this leads to differences in demographics between the groups. Those kids that were on modulators sooner in life may have been established at a different eye care center and more resistant to changing to the university setting. So the pharmacy listserv has actually had a lot of other eye potential connections to modulators, including styes, redness, dry eye, and vision changes. So I don't think that this connection with ophthalmology is going to disappear. And so I think that we will continue to have to find ways to integrate with other members of the care team. Once again, if we look back at that figure, this is going to come up a lot. So I know we're going to do a Q&A, but I would love to hear from others on some of these key discussion points. So what difficulties has your center encountered with eye monitoring? What do you think has worked well? And then as the CF care team grows, what additional education measures will you take? Because as we know, not all of these teams are going to be as familiar with CF as we are. And then lastly, I'd just like to acknowledge both my pediatric CF Center director, Dr. Viner, and then the 4 ophthalmologists that worked with us to collaborate on this project. And thank you.
So I'd like to invite all the speakers back up here, and then I'm going to go through some questions, and we can see which speaker needs to respond. I want to remind you guys to please use the microphone if you have any questions, or go ahead and send it to the app as well. And a big thank you to all of our speakers. Great job. So the first question I have is for Kelly. Do you have any experience to share to helping patients with alternative funding plans?
So I have, it's kind of case by case in my experience with the AFPs. They're all different, and they, in my experience, will change things at the last minute. So that's what makes it really hard to navigate them, because they just, like with our one patient, like it was literally after 5 months, they just like submitted a form and changed their whole like formulary. So that's kind of a hard question. Unfortunately, that's the best I got for that one.
When patients are looking at insurances, is there something that will notify them that it's an alternative funding plan? Like, is it in the title of the insurance plan? Do you know?
I don't believe so. Not in my experience. The only way that I was able to find out that our patient was enrolled in an AFP was when he went to get when they went to get their medicine, and they said that the billing wasn't handled by the primary insurance. It had been sourced out to a third-party program. So that's what should like raise a flag that you may be dealing with an AFP.
Okay. And I do want to add that we did have a comment from someone in the audience that said another important comment about AFP, they are not the health plan, healthcare clearinghouse, or provider, therefore they are not HIPAA-covered entities. And I did not know that, so thank you for whoever shared that as well. The next question is for Brittany. Do you have a similar collaborative care model with any other specialties, such as endocrinology?
Yes, so we have, I would say the 2 other subspecialties that I can think of are endocrinology, and we have a physician in GI that primarily focuses on CF liver disease and constipation, past just using Miralax. And they actually come to our clinic as well. Our pediatric specialty clinic is set up in pods. And so our patients, as soon as they walk through the door, they're told the room that they go to, so they don't wait in the waiting room. They go directly to the room, and then everyone comes to them, with the exception of ophthalmology because of their machinery. But that also just eases like everyone coming to one spot, because when the endocrinologist is getting ready to go in, she's walking right by the rest of the team that's sitting right outside of the patient door.
That's great. One more. Have you run into any insurance or cost barriers with patients being able to be seen at optho at the university versus outside?
Not to my knowledge. I think just upon reviewing the notes for the ophthalmologist, everyone gets coded with a high-risk medication usage, or like monitoring for a high-risk medication. That would be the same, for several other medicines outside of CF. So I'm sure with that coverage, they wouldn't run into anything. And as much as I deal with access and insurance and high cost, I'm fairly certain they would let me know if they did have a charge.
Couple more.
Okay.
Yeah. It was a very interesting presentation. I think definitely it's something that I would like to figure out how to do at our center. Do you know how long the eye exams take? Sometimes they take several hours. And do you send the patient down and then come to CF clinic, or it's optho close, I guess is the question.
Yeah, so our clinic, we have pods, like I said, so A, B, C, and D. So just to give you a perspective, pulmonary is in B and ophthalmology is in D, but it's very walkable. So they could come back and forth, which we sometimes have done. Our MAs in clinic are very quarterbacky, and so they just will tell you where to go. And so if they see someone in ophthalmology canceled or no-showed and the physician has an opening, well, they might sneak them over there to get started and then come back because we have 2 other CF patients waiting or something like that. You mentioned something else, Wendy, and I was going to just comment on it, but now I'm forgetting. What was the first part of that question?
Going back.
I must not be that important. I can't remember it. I'm sorry.
It was. But they do want to know, I guess, 2 more questions regarding this. Do you do any infection control training with the optho clinic staff? And do your ophthalmologists formally comment on papilledema?
Oh, yeah. Okay. And I actually did think of what I was going to say. One thing I've learned from patients' response, and I never thought about this, even though I wear glasses and have had a dilated eye exam, it can be scary for kids when they get an eye exam and their eyes go blurry. And I think that's something we underestimated as a care team. So I have tried to explain that to parents, especially if they don't wear glasses. And that sometimes does interfere with like other visits in between, because the kid's just scared, right? Like they don't know what's happening. They can't see their tablet. It hurt a little bit when they get the drop. It's just, there's a bunch of things. And so sometimes that does interfere with, maximizing every second of the patient experience. But yes, our ophthalmologist would still do standard precautions for contact precautions, even though it's in a different pod. And our patients are very well aware that if someone walks into the room that doesn't have gown and gloves, that they should remind them. But we have standard BPAs that fire in Epic to remind everybody.
Great. And do they check on or comment on papilledema?
Yeah, they will comment and include the pictures, which once again, this is all things I didn't know anything about until last year, but now being able to see, they'll include the imaging of the optic nerve.
Wonderful. Okay, question for Emily. Does your documentation include the documentation of the specialty pharmacy enough to count for their documentation for accreditation?
It used to, and I was getting a lot of feedback that it was too much, because it is too much. So I do still have to do our specialty pharmacy approved smart phrases within the chart. It's unfortunate, but It satisfies the accreditation requirements by it being in there. And then my annual note that goes above it, I find is what most people actually want to read, but I'm still checking the boxes for accreditation. It is relatively easy to incorporate it all back in if you're willing to have your note be longer, and that might be more efficient for you, but I've chosen not to do that now.
Great, thanks. All right, we do have a comment for Brittany. I've had difficulty with provider buy-in regarding the importance of tracking eye exams and getting records sent to the clinic. Definitely something to revisit as our team debriefs after the conference. So thank you for that. All right, any other questions from the group? Well, I want to thank this wonderful set of speakers. We appreciate all the information you've provided today, and I wish everyone a great conference. Thank you for coming.